First of all, I would like to thank the Philippine Orthopedic Association and the Assami group for inviting me. I'm going to speak about Ilizarov reconstruction around the hip. We can divide the reconstruction into traumatic conditions and non-traumatic conditions. For the traumatic conditions, the example is open fractures, like this case, infected open fractures, firearm injuries, osteoporotic fractures, like this case, infected fractures after open reduction, and infected non-union. We always use the closed reduction techniques in fractures around the hip. It seems like swimming against the current. People usually do open reduction internal fixation, but we prefer closed reduction techniques, like this picture of open infected fracture with comminuted fractures treated by closed reduction techniques using multiple threaded wires and compression, like this picture, and ended up with union. Another example of this osteoporotic fracture of the proximal femur. And we used multiple threaded wires and this half pin and closed reduction and union. Again, failure of open reduction and the infection, we removed it and used external fixation of the proximal femur. Another example, infected non-union in this case, and subluxed hip and the infected non-union of the upper femur. The patient was treated twice using Ilizarov and ended up with this infection. We removed everything and another corticotomy first technique. We applied corticotomy of the distal part and the frame to the proximal part. Again, we used distraction of the proximal part, gradual distraction. Again, and the distraction of the corticotomy site. And then side-to-side compression to do compression. And it ended up with complete union and the correction of the lower limb length discrepancy. These were the traumatic conditions. What about the non-traumatic conditions? We used the Ilizarov principles for arthrodiastasis or osteotomy. We have many indications like Perthes disease, avascular necrosis, osteoarthritis, chondrolysis, neglected hip dislocation, unstable capital femoral epiphysis, and adolescent arthritic hip. And this is an example of avascular necrosis after intramedullary nailing, fracture femur ended with avascular necrosis, and this is arthrodiastasis, and this is the picture. End picture. Again, in Perthes disease, the patient is 12 years old, and after failure of conservative treatment of this extrusion of this fragment, as you see here, pain and pelvic obliquity, and this is 3D picture. We did arthrodiastasis, gradual arthrodiastasis, and abduction, and this is with the follow-up. You see before, and you see during follow-up after 2 years, rounded hip. And see the picture. He can run, even play sports now, and he can squat. Proximal femoral focal deficiency. This type, apparent neck pseudarthrosis. And you see the 3D with a severe deformity. The first operation with the distraction of the proximal part of this apparent pseudarthrosis. Of course, this is fibrocartilaginous tissue. And the gradual correction between the proximal and distal fixation. You see, and lengthening too. And this is the end picture. Then after 3 years, We did this operation, osteotomy of the upper part to correct the deformity and lengthening, chondrodiastasis of the distal part, because we need a long distance of lengthening. And we applied the frame to the tibia to correct the fixed flexion knee deformity. Looks like 3 operations together. So this is the upper part, the middle part. We have chondrodiastasis for 20 centimeters and the correction of the flexion knee. You see here 20 centimeter lengthening, 20 centimeter lengthening. This is the picture before and this is after. Again, a case of super hip, which had been treated elsewhere, ended up with stiff hip, 70 degrees flexion and 70 degrees flexion knee, flexion hip, flexion knee. And was treated by arthrodiastasis to correct the flexion hip, corticotomy, and applied the frame to the tibia to correct the tibial deformity. And pelvic support osteotomy, my first pelvic support. And this is the picture. Follow-up after 13 years. You see the follow-up. And she can squat, which is an important move in our culture. And these are my papers, recent papers about pelvic support osteotomy, including our experience for more than 30 years with the pelvic support osteotomy. If you are interested, you can read more about the pelvic support. Our personal experience, until now, we have more than 180 cases. And this is the principle of the pelvic support. We have high osteotomy and low osteotomy, and we push the medial fragment medially. Ilizarov added another osteotomy here for lengthening and the correction of the mechanical axis. Is it a salvage procedure? We don't think so. So in, like this case, absent head and neck due to old septic arthritis, all these cases. Congenital short femur, you know, you don't have an acetabulum, it's impossible to reconstruct this upper part. Neglected fracture neck femur after 4 years and after 2 years. DDH, neglected DDH at the age 25. DDH after failure of 6 previous operations. Dysplastic hip and failure of 7 operations. This is avascular necrosis after safe surgical dislocation, the so-called safe surgical dislocation. Osteoarthritis, dying age, 22. Failure of arthroplasty, many times, and this is the end picture. It's fat people, fat person. Revision of pelvic support osteotomy done before. And usually before pelvic support, we let the patient and the family meet 2 other cases, old cases. And we ask the opinion of the arthroplasty surgeon who is professional in doing arthroplasty in lying age. And this is an example of one of the cases, which had been treated with pelvic support for follow-up for 21 years and total hip for follow-up for 7 years. The level of support can be high support, acetabular, and low support. People claim that high acetabulum may do impingement, but this is not true. Like this patient was followed up more than 20 years, and she can squat. This is the low support at the ischial tuberosity. This is high support at the acetabular edge. You see. In our experience, we always do lengthening, over lengthening by 1.5 centimeters because of the telescoping during walking. So it's not just we correct the axis, but we do usually over lengthening, like these cases. Remember, in the very young age, we always have recurrence of the deformity. So the body treats the upper pelvic support as a deformity, and within few years, it will correct it. We do have complications in the older age. This is 32 years old, man who had DVT after treatment. Again, example of pelvic support in congenital short femur, proximal femoral focal deficiency. And this patient, this is preoperative of this plastic hip. Photo, video. So you have this plastic hip after in the left side, left-hand side, left side, adduction, deformity. We did pelvic support osteotomy first. And this is during follow-up after a few years. You see the way she walks. Then she came later on, at the older age, with osteoarthritis and pain. And she preferred to do total hip on the other side. And this is after pelvic support for 21 years and arthroplasty for 7 years. She has high heels. In conclusion, Ilizarov method is effective in treating many traumatic and post-traumatic conditions around the hip. The real merit of the use of circular fixator as definitive treatment is closed operative treatment of fractures. Gradual post-operative reduction during follow-up is also possible without anesthesia or analgesia. Long and mid-term results of Ilizarov modification of pelvic support osteotomy are encouraging. Thank you.